Welcome you. This is Monday Morning Panic, your super fast, highly concentrated review for that big nursing school final. We have a lot to cover, so let's jump right in.
Absolutely. We're distilling down the critical info from a comprehensive study guide. Focus is key here. Everything we touch on is crucial for your exam success.
First off, a quick note on dosage calculations. Your exam blueprint mentions 5 fill-in-the-blank questions, but our source material doesn't give specific content for those.
Right, so just make sure your general calculation skills are sharp. You'll need them.
Okay, moving into mobility. Let's hit amputation education.
Yeah, post-op stump care is huge. You need to apply a compression bandage immediately after surgery.
And that gets reapplied often.
3 to 4 times a day, yeah. Remove it, reapply it. Once it's healed, though, it's only used when the prosthesis isn't on.
Okay.
And don't forget range of motion exercises with the affected limb. Super important to prevent contractures.
Got it. And the different types.
Yeah.
Close amputations versus open.
Exactly. Close are designed for a weight-bearing limb eventually.
Yeah.
Open, or guillotine, those are usually for severe infections. They might need later procedures, cautery or skin grafts.
Okay, now, priority nursing interventions and fractures. Emergent care first.
Immobilization. That's priority 1. Prevent any movement with temporary splinting.
What if there's bleeding?
Sterile bandages for hemostasis. And crucially, you absolutely do not attempt to reduce or fix the break yourself. Leave that to the pros.
Right.
Inspect the wound, check the pulse, and always assess the 5 Ps. Pain, pulse, pallor, paresthesia, and paralysis.
Okay, those 5 Ps keep coming up. Cover open breaks.
Immediately. Prevent infection.
For hip fractures, specifically.
Remember that abduction pillow. Keep the hip in the right position. Pain management is huge, obviously. Plus vitals, and yes, those 5 Ps again.
And cast care.
Well, casts dry pretty fast, about 30 minutes now. Always elevate the limb. Prevent that compression.
And check the 5 Ps.
Constantly.
Huh.
Also let the patient know the cast saw is loud, but it won't cut their skin. That helps ease anxiety.
Good point. Traction.
Yeah.
What's the big rule?
Never interrupt therapy. Seriously. Make absolutely sure those weights hang freely. If they're resting on something, the traction isn't working.
Okay. For bucks traction.
Keep the patient midline in bed, and you've got to assess for pressure injuries from that boot or cuff. Skin breakdown is a risk.
Makes sense. Skeletal traction. Pin care.
For pin care, if you see crusty drainage, just leave it alone. It can actually be protective.
But what if you can't see the pin caps?
That's different. If you can't visualize the pin caps on assessment, call the surgeon immediately. Could be a problem with the pin itself.
Wow, okay. And then neurovascular assessment frequency. How often for those 5 Ps?
It's intense at first, every hour for the first 24 hours. Then you could usually go to every 1 to 4 hours after that.
And report changes?
Promptly report any changes. Early detection of neurovascular compromise is absolutely vital.
Okay, let's talk compartment syndrome. What are the cues?
This means inadequate blood flow to tissues. It's an emergency. Signs are those 5 Ps again, but the pain, it's the key.
How so?
It's pain that's uncontrollable, way out of proportion to the injury, and especially bad with passive stretching of the muscle.
Okay, disproportionate pain. What else?
You'll also see the other PS pallor, maybe pulselessness, paresthesia, that numbness and tingling, and eventually paralysis. Also a feeling of tightness and muscle weakness.
If you suspect it, what's the immediate action? Elevate.
No.
Yeah.
Do not elevate the limb. That can actually make it worse by reducing arterial flow. Prepare for a fasciotomy, that surgical cut, to relieve the pressure.
Got it. Switching gears to osteoporosis.
Defined as diminished bone density. Key risk factors. Prolonged use of proton pump inhibitors, PPIs. Think omeprazole and corticosteroids like prednisone.
What else?
Alcohol use, family history, and a big one, being a postmenopausal woman because of lower estrogen. Also, inadequate nutrition, specifically low calcium and vitamin D.
So prevention involves?
Adequate calcium intake and vitamin D is crucial for absorption, plus weight-bearing exercises. Think walking, jogging, lifting weights that strengthens bones.
And things to avoid.
Avoid alcohol, caffeine, and tobacco. Also, be aware of at-risk populations. Kids with spina bifida, adolescent athletes, pregnant women, because the baby leaches calcium.
How's it diagnosed?
DEX studies, that's the gold standard for bone mineral density. X-rays. They might find a fracture after it happens, but they aren't sensitive for early detection of bone loss itself.
Okay. Medications. Calcitonin.
That's a nasal spray. Key point. Alternate nostrils with each dose to prevent irritation.
And bisphosphonates like Fosamax, Actonel, Buniva.
Big instructions here. Take them on an empty stomach first thing in the morning with a full glass, about 250 milliliters of plain water.
And then?
And then the patient must sit upright for at least 30 minutes. Cannot lie down. This prevents esophageal irritation.
That's critical. Anything else?
They're often taken just once a week
Uh-huh.
and absolutely report chest pain immediately. Could signal esophageal issues. Also ensure adequate calcium intake alongside these meds.
Okay. Phantom limb pain. How do we assess that?
Just like any other pain, use a 1 to 10 scale. Ask the patient to describe it. It can feel like coldness, heaviness, cramping, shooting, burning, or even crushing pain in the missing limb.
Got it. And some general pharmacologic therapy for mobility pain over the counter.
Sure, acetaminophen helps with pain, but remember, zero anti-inflammatory effect. Salicylates, like aspirin, hit pain, inflammation, and fever, but watch those anticoagulant effects.
Right, bleeding risk. And NSAIDs, ibuprofen, naproxen.
Good for reducing pain and inflammation. Main watch-out is GI side effects, upset stomach, bleeding risk.
Prescription muscle relaxers, Larisil, Xanaflex.
They relieve spasms, which is good, but be really vigilant for respiratory depression and lethargy. These can be significant side effects.
And a huge warning.
Never combine them with opioids.
Oh.
That combination dramatically increases the risk of respiratory depression. Very dangerous.
Okay, let's dive into segment 2. IVs, blood, and tissue integrity, starting with IV fluids and tonicity.
Right. Isotonic solutions, like 0.9% normal saline, lactated ringers, D5W, they have an osmolality of about 270, 300. They basically stay in the blood vessels.
And the key point about normal saline.
Normal saline is the only fluid compatible with blood transfusions. Remember that one?
Okay, hypotonic solutions.
These are less concentrated, under 270 ml/kg. Think half normal saline, 0.45% ACL or D2.5W. They shift fluid into the cells and tissues. Good for dehydration at the cellular level, or maybe hypernatremia.
Important warning about D5W.
Yes, D5W should not be given to pediatric patients. The dextrose gets metabolized quickly, leaving free water, which can cause hyponatremia and dangerous cerebral swelling in kids.
Wow, critical point. Hypertonic solutions.
Over 300 ml/kg, D5NS, D10W, 3% normal saline. These pull fluid out of the tissues and into the vasculature, used to reduce edema, especially cerebral edema, or treat severe hyponatremia.
And 3% ACL specifically?
Used very carefully for severe hyponatremia, yeah. It pulls fluid out fast.
The difference between crystalloids and colloids.
Crystalloids like saline, LR, have small solutes, give a fast response, but don't stay in the vessels long, short duration. Colloids like albumin have large molecules, give a slower response, but stay in the vasculature much longer, long duration.
Albumin's role.
It maintains oncotic pressure, holds fluid in the vessels, generally avoiding simple fluid volume deficit because it can affect coagulation, but you might see it used in liver disease to help with ascites.
Okay, let's hit IV complications. Local ones first. Infiltration.
That's when non-irritating fluid leaks out into the surrounding tissue. The site will feel cool to the touch, swollen, maybe pale.
Interventions.
Stop the infusion immediately, take the IV out, and start a new one somewhere else, usually the other arm if possible.
Extravasation.
Similar leak, but this time it's an irritating medications.
Yeah.
Think potassium, amiodarone, chemo drugs, causes redness, pain, potentially tissue necrosis, severe inflammation. Very serious.
Phlebitis.
That's inflammation of the vein itself. You'll see redness, warmth, maybe tenderness along the vein path.
Thrombophlebitis.
That's phlebitis, plus a blood clot formation in the vein.
And hematoma.
Just bruising, basically. Blood leaks into the tissue around the site. Often happens if the needle goes through both sides of the vein during insertion, or maybe the angle was off.
Systemic complications. Fluid overload.
Too much fluid volume. Look for edema, high blood pressure, tachycardia, crackles in the lungs, maybe pulmonary edema, and definitely jugular vein distension, JVD.
Air embolism. How much air is dangerous?
Any amount, really. It can block pulmonary vessels. Look for diminished breath sounds, dropping O2 sats.
Intervention is key here.
Absolutely critical. First, clamp the IV line immediately. Assess their airway, breathing, circulation, get vitals. Then, the position. Turn the patient on their left side in Trendelenburg position. This traps the air in the right ventricle, preventing it from going to the lungs.
Wow, okay. Septicemia and other infections?
Preventable. Remember to scrub the hub vigorously for at least 10-15 seconds before accessing any port or connection.
Good reminder. IV access devices and RN responsibilities.
Well, you have your basic peripheral IVs, short term. Midlines go deeper into a larger vein than central lines. PICCs, tunneled catheters, non-tunneled like subclavian, and implanted ports.
Difference between implanted ports and power flush.
Standard implanted ports usually can't handle the pressure for contrast dye injections. Power flush ports can. Important distinction for imaging.
And the RN's role.
Selecting the right site in cannula size, making sure the line isn't kinked or bent, and constantly monitoring the patient's response site assessment, fluid status, tolerance.
Okay, blood administration, education, and intervention.
Right. Main component used is packed red blood cells, PRBCs, usually for anemia. Whole blood isn't common anymore. And the absolute rule, you cannot mix medications with blood products, only normal saline.
Before starting, what needs to happen?
Confirm the type and screen or cross-match is done and compatible. Get baseline vital signs. Educate the patient on signs of reaction. Get signed consent, which the nurse witnesses. Verify the order against a blood bag with another RN. Gather all your supplies, correct tubing, saline.
Monitoring during the transfusion, timing is critical.
Yes. Must start the infusion within 30 minutes of the blood leaving the blood bank. And the whole unit must be infused within 4 hours max to limit bacterial growth risk.
How fast do you run it?
Start slowly, maybe 5 millimolar per minute for the first 15 minutes.
Yeah.
Stay with the patient. If no reaction, you can increase the rate.
Vitals.
Check vital signs again at 15 minutes, then typically every hour during the infusion, and again about an hour after it's done to watch for delayed reactions. The nurse's role is constant vigilance, verifying everything, observing the patient closely.
Transfusion reaction priority. What if one happens?
Stop the infusion immediately. That's the first most critical step. Then assess the patient, check their vitals, and contact the provider right away. Keep the IV line open with saline.
Types of reactions. Febrile, non-hemolytic.
Pretty common, especially in women who've had multiple babies or patients with many prior transfusions. Main sign is chills followed by fever. Usually not severe.
Acute hemolytic reaction.
This one is severe, often due to ABO incompatibility. Look for back pain. That's a classic sign from acute kidney injury, plus fever, chills, shortness of breath, maybe hematuria. Life-threatening.
Ooh, allergic reaction.
Can range from mild hives, urticaria, and itching, pruritus, to severe anaphylaxis. Treatment depends on severity, antihistamines for mild, epinephrine for anaphylaxis. Transfusion-associated circulatory overload. Take out.
So it's like fluid overload.
Exactly. It's basically giving the fluid too fast or too much for the patient's circulatory system. Presents with shortness of breath, tachycardia, hypertension, and JVD. Need to slow down, maybe give diuretics.
Bacterial contamination.
Rare, but serious. Causes sudden high or low blood pressure, severe chills, rigors, maybe collapse. Treated like sepsis.
Transfusion-related acute lung injury. TRLEI.
Acute respiratory distress. Looks like ARDS. Non-productive cough, trouble breathing usually happens within 6 hours of the transfusion. Need respiratory support.
And delayed hemolytic reaction.
This one is sneaky. Happens days to weeks later. Often subtle signs like fever, general malaise, maybe mild jaundice. It's due to less common antigen incompatibility. Often goes unnoticed unless labs are checked.
Okay, quick review of tissue integrity. Wound staging.
Right. Stage 1. Intact skin, but it has non-blanchable erythema redness that doesn't turn white when you press it.
Stage 2. Partial thickness skin loss. Looks like a blister or a shallow open sore. The dermis is exposed.
Stage 3. Full thickness tissue loss. You can see subcutaneous fat, but no bone, tendon, or muscle is exposed.
Stage 4. Full thickness loss where you do see exposed bone, tendon, or muscle. SLA or Escher might be present.
Unstageable.
That means the base of the wound is covered by SLA, that yellow, tan, gray stuff, or Escher, the black, leathery, dead tissue. You can't actually see how deep it is until that's removed.
Got it. Interventions for prevention and healing. Healing intentions.
First intention. Clean surgical incision, edges approximated, closed with stitches or staples. Minimal scarring.
Second intention. Wound is left open. Heals from the bottom up by granulation. Think pressure ulcers. Takes longer. More scar tissue.
Third intention, also called delayed primary closure. Wound is initially left open, maybe is contaminated, then later closed surgically once it's clean.
Phases of healing.
Inflammatory phase, first few days, 3-6 days maybe. Clotting happens, macrophages clean things up.
Proliferative phase, day 3 or 4 to about 3 weeks. Collagen is laid down, new capillaries form, granulation tissue builds up.
Maturation phase?
Right, that can last a long time, day 21 up to 1-2 years. Collagen gets remodeled, scar tissue strengthens. This is where keloids can form if things go awry.
Granulation tissue, what does it look like?
Healthy granulation tissue is beefy red or pink, moist, bumpy. It's new tissue forming. You absolutely want to protect this tissue. Don't scrub it away.
Okay. Drainage types. Serous.
Clear, watery plasma, like fluid from a blister.
Purulent.
Thick yellow, green, tan, or brown.
Mhm.
Indicates infection. Contains pus.
Sanguineous.
Bright red indicates active bleeding. Bloody drainage.
Serosanguinous.
Pale, pink, watery. A mixture of serious and sanguineous. Common in early wound healing. Dehiscence versus evisceration. Big difference. Dehiscence.
That's when a wound, usually a surgical incision, partially or fully separates, but underlying tissues like fat or muscle might be visible, not organs sticking out.
Intervention for dehiscence.
Cover it with a sterile dressing soaked in sterile saline. Notify the provider.
Evisceration.
This is a surgical emergency. The wound separates completely, and an internal organ actually protrudes through the opening.
Intervention for evisceration. Critical steps.
Okay, first, call for help. Stay with the patient. Place the patient in low Fowler's position with knees slightly bent to reduce abdominal pressure. Cover the protruding organ immediately with a sterile dressing moistened with sterile normal saline. Keep it moist. Notify the surgeon immediately. Make the patient MPO. This needs urgent surgery to prevent tissue necrosis.
Perfect. Segment 3. Elimination, nutrition, cellular regulation, starting with ulcers.
Peptic ulcer disease, PUD. Key difference in pain pattern.
Duodenal ulcer pain is often relieved by eating because food buffers the acid. Gastric ulcer pain is typically worsened by eating, as food stimulates acid secretion, which irritates the ulcer.
Main cause.
H. pylori bacteria is the big one.
And the critical complication.
Perforation. Look for sudden, severe upper abdominal pain and a rigid, board-like abdomen due to peritonitis. This is a surgical emergency.
Signs of bleeding.
Hematemesis, vomiting blood, might look like coffee grounds, or melena, which is black. Tarry stools from digested blood.
Key avoidance.
Patients must avoid NSAIDs. They inhibit prostaglandins that protect the stomach lining.
H. pylori treatment.
Often triple therapy. Usually 2 antibiotics like clarithromycin and amoxicillin, plus a PPI. Smoking is also a major risk factor. And advise small, frequent meals.
Okay. GERD, gastroesophageal reflux disease. Problem.
Weak lower esophageal sphincter, LES. Allows stomach acid to backflow into the esophagus.
Key interventions.
Elevate the head of the bed on blocks, not just pillows. Use gravity. Avoid eating 2-3 hours before lying down. Stay upright for a bit after meals.
Foods to avoid.
Things that relax the LES. Caffeine, fatty foods, chocolate, peppermint, alcohol. Elderly might present differently, right? Yeah, maybe with chest pain mimicking angina, or respiratory symptoms like cough or aspiration, not just heartburn.
Meds for GER.
Antacids for quick relief.
Yeah.
BPIs are very effective, but remember that long-term use increases osteoporosis risk. H2 blockers like famotidine are another option.
Complication. Hallmark symptom.
A serious complication is Barrett's esophagus, a precancerous change. The hallmark symptom, though, is pyrosis heartburn.
Celiac disease. What's the trigger?
Gluten. It's a protein found in wheat, barley, and rye. Ingesting it damages the villi in the small intestine.
And the treatment?
There's only one. A lifelong, strict, 100% gluten-free diet. No cheating. There are no medications that treat the underlying disease.
Hallmark symptom.
Steatorrhea. That's fatty, foul-smelling, often floating stools due to fat malabsorption.
Diagnostic point.
For accurate testing, the patient must be actively eating gluten during the diagnostic workup. Otherwise, tests might be falsely negative. Also, educate heavily on hidden gluten sources. Risk for anemia, osteoporosis.
Okay, pediatric diseases. Cleft lipolid. Feeding.
Use a special compressible bottle, maybe with a longer nipple. Feed the infant in an upright position to minimize aspiration risk. And burp frequently because they swallow a lot of air.
Post-op care for palate repair.
Position the infant on their side to allow drainage of secretions. Gently clean the suture line with sterile water or saline after feedings. Avoid pacifiers or hard objects in the mouth. Sometimes elbow restraints are needed to keep fingers out of the mouth.
Long-term risks.
Ear infections and potential hearing loss due to eustachian tube dysfunction.
Pyloric stenosis, the big sign.
Projectile vomiting. It gets progressively more forceful. Classic finding on exam is a palpable olive-shaped mass in the epigastric area, usually to the right of the umbilicus.
What does the vomiting lead to?
Metabolic alkalosis because they're losing stomach acid. Also dehydration and hypokalemia. The infant is typically hungry and irritable right after vomiting, wants to eat again.
Pre-op priority.
Correcting the dehydration and electrolyte imbalances with IV fluids. Surgery can wait until the baby is stabilized.
Post-op care. Yeah.
Infant is NPO until the surgeon says okay. Then, feedings start very slowly, usually with small amounts of clear liquids like Pedialyte. Report fever over 101.3 or any vomiting after starting clears.
Hypospadias. What is it?
The urethral opening isn't at the tip of the penis, but on the ventral side, the underside.
Critical point about circumcision.
The infant should not be circumcised. The foreskin is often needed by the surgeon to reconstruct the urethra during repair.
Post-op care.
A catheter or a stent will likely be in place to keep the urethra open while it heals. Use double diapering. Cut a slit in the inner diaper for the penistent, then place that inside a larger outer diaper. This keeps stool away from the surgical site. Anticholinergic meds like oxybutynin help prevent bladder spasms.
And a note, our sources didn't cover encopresis versus enuresis differentiation.
Okay. Renal calculi kidney stones. #1 risk factor.
Dehydration. Concentrated urine allows minerals to crystallize. Encourage high fluid intake, 2-3 liters per day unless contraindicated.
Hallmark symptom.
Renal colic. It's excruciating, sharp pain, usually starting in the flank or back, and often radiating down to the groin. Patients are often restless, can't find a comfortable position.
Nursing care focuses.
Pain management is critical. That pain is severe. Also, strain all urine to catch any past stones. Send them to the lab for analysis to figure out the type and guide prevention.
Post-lithotripsy.
Bruising on the flank where the waves were aimed and hematuria, blood in the urine, are expected findings after the procedure.
Okay. IBD, inflammatory bowel disease, both Crohn's and UC.
Avoid cold foods and smoking as they can trigger symptoms. Diagnostics include blood tests showing elevated ESR and CRP, inflammation markers,
Wow.
and colonoscopy is key for visualization and biopsy.
Let's differentiate Crohn's disease.
Can affect any part of the GI tract, mouth to anus. Inflammation occurs in patches, skip lesions with healthy tissue in between. It typically spares the rectum. Inflammation is transmural, going through all layers of the bowel wall, giving that cobblestone appearance. High risk for fistulas and strictures. Surgery is not curative. Diarrhea is usually non-bloody.
Ulcerative colitis.
C. Limited to the colon and rectum. Inflammation is continuous, usually starting in the rectum and spreading upwards. Hallmark symptom is bloody diarrhea. Inflammation is superficial, just the mucosal layer. A total proctocolectomy is curative. Big complication risk. Toxic megacolon.
Moving to bowel obstruction.
Mm-hmm.
Key difference between SBO and LBO.
Small bowel obstruction, SBO, usually has a rapid onset with profuse vomiting, often early on. Large bowel obstruction, LBO, tends to have a more gradual onset, with marked abdominal distension being prominent.
Bowel sounds.
Early on, they're often hyperactive and high-pitched, sometimes called tinkling, as the bowel tries to push past the blockage. Latent obstruction sounds become hypoactive or absent. SBO vomit can eventually become fecal smelling. Pain is usually severe, crampy, comes in waves, colicky. High risk for dehydration and hypokalemia.
With strangulation.
That's when the blood supply to the obstructed bowel segment is cut off. It's a surgical emergency. Signs include fever, tachycardia, and severe continuous pain, not colicky.
Priority interventions for obstruction.
NPO. Rest the bowel completely. Insert an NG tube and set to low suction for decompression, removing fluid and gas. Administer IV fluids to correct dehydration and electrolyte imbalances. Prepare for possible surgery.
UTI, urinary tract infection. Atypical presentations.
Especially in the elderly. New onset confusion or combative behavior might be the only sign. In kids, often just a nonspecific fever.
Diagnosis key point.
Obtain a clean catch midstream urine specimen before starting any antibiotics. Need that culture to identify the bacteria and guide treatment.
Most common cause.
Yeah.
Classic symptoms.
Usually E. coli from the gut. Hallmark symptoms of cystitis, bladder infection, are dysuria, burning, frequency, and urgency.
Prevention tips.
Wipe front to back. Void after intercourse. Avoid douching and spermicidal contraceptives. Avoid tight synthetic underwear. Wear cotton. Drink plenty of fluids.
Patient education on treatment.
Complete the full course of antibiotics even if they feel better after a few days. Stopping early leads to recurrence and resistance.
Meds. Pyridium.
Antibiotics like Bactrim or Macrobid are common. Phenazopyridine, pyridium, is only for pain relief analgesic. Tell patients it's normal for it to turn urine and other body fluids bright red or orange. It's not an antibiotic and should only be used for 2-3 days. Also report any yellowing of skynes, as jaundice. All right, deep breath. Cellular regulation, starting with diabetes and priority interventions. Diagnostic labs.
Fasting glucose. Normal 70-100. Prediabetes 101-125. Diabetes is 126 or higher on 2 occasions. A1C reflects average glucose over 2-3 months. Goal for diabetics is usually less than 7%. Random glucose over 200 with symptoms can diagnose type 1. Lipid goals. HDL 35, triglycerides 150.
Diabetic emergencies. Hypoglycemia, low blood sugar.
Unconscious patient.
Glucagon intramuscularly or dextrose 50% D50 IV. Can't give anything oral.
Conscious patient.
Fast-acting carbs. 15 grams like 4-ounce juice. Glucose tabs. Recheck sugar in 15 minutes. Once it's above 70, follow up with a snack containing carbohydrates and protein to prevent another drop. Maybe a snack before bed, too, to prevent overnight lows.
DKA, diabetic ketoacidosis, more common in type 1. Key features.
Severe insulin lack leads to burning fat for energy. Look for ketones in urine blood, small respirations, deep, rapid breathing trying to blow off acid, and a fruity odor to the breath from acetone. Also hyperglycemia, dehydrogenation, acidosis. HHS, hyperosmolar hyperglycemic state, more common in type 2, especially older adults. Distinguishing factor.
The main difference is the absence of significant ketosis and acidosis. Blood sugar is extremely high, often over 600 milli-GDL. Hallmark signs are severe dehydration, profound hyperglycemia, and altered mental status. Also hypotension, weakness.
Treatment for both DKA and HHS. Priorities.
Okay, stepwise approach. 1. Rehydration therapy. Start aggressively with normal saline IV. 2. Insulin administration. Regular insulin IV infusion is standard. Bring glucose down slowly. 3. Electrolyte correction. Monitor potassium very closely. It drops as insulin pushes it into cells. Replace as needed. 4. Airway management if LOC is depressed. 5. Identify and treat precipitating factors, infection, missed insulin, etc.
Sick day rules for diabetics.
Crucial education. Continue taking insulin, maybe even more than usual, as illness raises blood sugar. Drink lots of liquid, sugar-free if possible, but if they can't eat, even sugary drinks are okay to prevent dehydration and provide some carbs. Monitor glucose frequently. Do not exercise if blood glucose is over 250 or if ketones are present.
General diabetes education.
Diet. Focused on high fiber, minimally processed carbs, portion control. Exercise. Aim for 150 minutes per week of moderate aerobic activity. Oral meds. Metformin is common first line for type 2. Inhibits liver glucose production. Must be held before procedures using contrast dye due to risk of lactic acidosis if kidney function is impaired. Glipizide stimulates the pancreas to release more insulin. Emphasize glucose monitoring, insulin self-management if applicable, and preventing complications like diligent foot care.
Okay, cirrhosis management. Signs and symptoms are numerous.
Yeah, the liver does so much. Look for significant third spacing and edema, especially ascites, fluid buildup in the abdomen. This leads to increased abdominal girth and rapid weight gain. Labs will show decreased serum protein and albumin because the liver can't make them, but increased ALT, AST, GGT, liver enzymes, and bilirubin.
What does high bilirubin cause?
Clay-colored feces because bile isn't reaching the gut. Tea-colored urine as kidneys excrete excess bilirubin, and jaundice. Also, the liver makes clotting factors, so expect a decrease in those, leading to increased bleeding risk, bruising easily, hematemesis, melena, hematuria.
Electrolytes, ammonia.
Often see increased sodium due to fluid retention hormones and decreased potassium. Increased ammonia is a huge problem because it's toxic to the brain, causing hepatic encephalopathy, confusion, personality changes, asterixis, flapping tremor, progressing to coma.
Portal hypertension consequences.
High pressure in the portal vein backs up blood flow. This leads to toxin buildup, contributing to encephalopathy, development of esophageal varices, fragile, swollen veins in the esophagus, high risk of massive bleeding, and splenomegaly.
Other signs?
Pruritus, itching from bile salts under the skin, spider angiomas, small dilated blood vessels, pulmar erythema, red palms, and that characteristic sweet musty odor to their breath called fetor hepaticus. Also, respiratory distress can happen just from the pressure of the sites in the diaphragm.
Medications for cirrhosis complications.
Lactulose is key for high ammonia. It traps ammonia in the gut and causes diarrhea to excrete it. Goal is usually 3 to 5 loose stools per day. Spironolactone is a potassium-sparing diuretic often used for ascites. Warn patients to avoid salt substitutes high in potassium. Beta blockers can help lower portal pressure and reduce the risk of variceal bleeding.
Priority interventions.
Elevate the head of the bed to ease breathing if ascites is present. Monitor daily weights and abdominal girth closely to track fluid status. For safety, keep nails short and filed due to pruritus and bleeding risk. Paracentesis removes acidic fluid, provides symptomatic relief, but draining too much fluid too quickly can cause hypovolemic shock due to fluid shift. A TIPS procedure creates a shunt to reduce portal hypertension, but can worsen encephalopathy.
Dietary management.
Sodium restriction, often to Godot, and usually fluid restriction to manage edema and ascites. Protein restriction is generally avoided nowadays unless encephalopathy is severe and unresponsive, as patients are often malnourished. Provide IV glucose to minimize protein breakdown if MPO, and vitamin supplements, especially B vitamins, fat-soluble. Monitor mental status meticulously.
Critical patient education.
Complete cessation of alcohol is non-negotiable if alcohol is the cause. Do not scratch itchy skin. Use lotions, cool baths. Do not strain during bowel movements. Use stool softeners to prevent increased pressure and variceal bleeding. Avoid NSI aids and anticoagulants due to bleeding risk.
Thyroid disorders. Let's contrast hyper and hypo. Hyperthyroidism, like Graves' disease.
Think everything is sped up. Patients feel hot, experience weight loss despite increased appetite, heat intolerance, excessive sweating, diaphoresis, cardiac, tachycardia, palpitations,
Neurocycle.
anxiety, irritability, insomnia, fine tremors, physical, maybe a goiter, enlarged thyroid, and exophthalmos, bulging eyes is classic for Graves.
Hypothyroidism, like Hashimoto's.
Think low and slow. Patients feel cold, experience weight gain, fatigue, lethargy, cardiac, bradycardia, depression, decreased cognition, brain fog, physical, expressionless face, puffy face eyes, dry skin, constipation. Huge point. They're very sensitive to sedatives and opioids due to slowed metabolism. Need lower doses.
Thyroid emergencies.
Yeah.
Thyroid storm.
This is hyperthyroid crisis.
Yeah.
Life-threatening, extremely high fevers, severe tachycardia, dysrhythmias, altered mental status, delirium, coma. Priority. Control cardiac function, often with beta blockers. Continuous cardiac monitoring is essential. Use cooling measures. Reduce environmental stimuli.
Myxedema, coma.
This is a hypothyroid crisis.
Whoa.
Also life-threatening. Patient becomes severely hypothermic, unconscious, hypoventilates. Highest priority is maintaining airway patency, often requiring mechanical ventilation. Keep him warm passively. Provide rest. And again, be extremely cautious with sedatives, opioids, and anesthetics. Even small doses can cause profound respiratory depression.
General thyroid education. Lifelong meds.
Often, yes, medication adherence is lifelong, especially for hypothyroidism. Levothyroxine is the standard for hypo. Key teaching. Take it on an empty stomach, usually 30-60 minutes before breakfast, with only water, and do not switch brands without provider consultation, as bioavailability can differ.
Lifestyle adjustments.
For hypothyroidism, avoid cold, high-fiber diet for constipation, maybe lower calorie sodium. For hyperthyroidism, need high-calorie, high-protein, frequent small meals due to high metabolism. Low fiber might help if diarrhea is an issue, and patients need to know the signs of thyroid storm or myxedema coma and seek help immediately. Radioactive iodine is a common treatment for Graves.
Segment 4. Fluids, electrolytes, gas exchange, perfusion, starting with fluid and electrolytes, ABG analysis.
Right, arterial blood gases.
Yes.
Essential for acid-base balance. pH 7.35, 7.45 is the main indicator. Lower is acidic, higher is alkaline. Bicarbonate, HCO3 2226, reflects the metabolic component regulated by kidneys. PaTO2 3545 reflects a respiratory component regulated by lungs.
Okay, pathophysiology and fluid shifts. Fluid volume deficit, FVD, hypovolemia.
Less fluid volume than normal. Causes: GI losses, vomiting, diarrhea, sweating, bleeding, decreased intake, diabetes insipidus. Symptoms: think dehydration, severe hypotension, tachycardia. Heart tries to compensate. Rapid, weak, thready pulse, orthostatic hypotension, confusion, poor skin turgor, dry mucous membranes, decreased urine output, thirst, priority. Fluid resuscitation, usually with IV isotonic fluids like normal saline. Big fall seizure risk.
Fluid volume overload, FVO, hypervolemia.
Too much fluid volume. Causes: excessive IV fluids, heart failure, kidney failure, can't excrete fluid. Symptoms: think fluid backup, rapid bounding pulse, hypertension, tachycardia, dyspnea, crackles in the lungs, potentially pulmonary edema, engorged neck or hand veins, JVD, pitting edema. Treatments: fluid and sodium restriction, diuretic therapy like furosemide.
Metabolic acidosis, low pH, low bicarb.
Right, depresses the CNS.
Yeah.
Causes: DKA, kidney failure, uremic acidosis, lactic acidosis, shock, toxic congestions, aspirin, methanol, severe diarrhea, losing bicarb. Symptoms: confusion, headache, lethargy leading to coma, customol respirations, the body's attempt to blow off CO2 to compensate. Arrhythmias often causes hyperkalemia initially as H+ ions shift into cells, pushing K+ out. Treat the underlying cause. Maybe give sodium bicarbonate IV cautiously.
Metabolic alkalosis, high pH, high bicarb.
Causes: loss of acid, like from severe vomiting or NG suctioning. Also, diuretic use, steroid use. Symptoms often related to neuromuscular irritability due to associated calcium shifts, like tingling, dizziness, hypotonic muscles. Treat the cause, maybe give fluids, replace electrolyte.
Respiratory acidosis, low pH, high PaCO2.
Problem is retaining CO2 due to hypoventilation. Causes: airway obstruction, COPD, asthma attack, CNS depression, opioid overdose, head injury. Symptoms: neurologic depression, headache, confusion, drowsiness, coma, rapid, shallow respirations initially, then slowing, dyspnea, tachycardia. Priority: treat the underlying cause of hypoventilation. Improve ventilation, positioning bronchodilators, reverse opioids, mechanical ventilation if needed. Don't give sedatives.
Respiratory alkalosis, high pH, low PaCO2.
Going off too much CO2 due to excessive breathing.
Hyperventilation.
Causes: anxiety, fear, pain, hypoxia. Body tries to get more O2. Aspirin toxicity, stimulates respiratory center. Symptoms: lightheadedness, dizziness, tingling, maybe carpopedal spasms. Priority: treat the underlying cause. If anxiety, help them slow their breathing. Paper bag rebreathing is controversial, maybe just coaching.
And remind us about third spacing.
That's when fluid shifts out of the vascular space into an area where it's not readily available for circulation, like the abdomen and ascites, seen in cirrhosis, or tissues in severe burns or sepsis. It contributes to hypovolemia, even if total body water is high.
Potassium cues. Normal range.
3.5 to 5.0 milli-UQL. Critical for nerve and muscle function, especially the heart.
Hyperkalemia. Potassium 5.0. Most common cause.
Chronic kidney disease is a big one. Impaired excretion. Symptoms: the most dangerous are life-threatening cardiac arrhythmias. Look for EKG changes, peak T waves, early sign, prolonged PR interval, widened QRS complex, flattened P waves, progressing to VFib and cardiac arrest. Also, muscle weakness, flaccid paralysis. Priority intervention for hyperkalemia.
If there are EKG changes or K+ is very high, administer IV calcium gluconate or chloride immediately. This doesn't lower potassium, but it stabilizes the cardiac membrane to prevent fatal arrhythmias. Then work on lowering K+, shift it into cells, insulin with glucose IV, sodium bicarb, remove it from the body, kioxalate, diuretics like furosemide, hemodialysis. Continuous cardiac monitoring is essential. Hypokalemia, potassium 3.5, causes
excessive GI losses, vomiting, diarrhea, and G-suction, potassium-wasting diuretics like furosemide, thiazides, inadequate intake. Symptoms: also cardiac arrhythmias, EKG, flattened or inverted T waves, depressed ST segments, prominent U waves, increased risk for torsades de pointe, also causes muscle weakness, cramps, decreased reflexes, potential paralysis. Treatments: safety.
potassium chloride replacement oral, often irritating, give with food.
Helpful.
Or IV. Must be diluted. Never push IV. Infuse slowly via pump. Check magnesium levels too, as hypomagnesemia often occurs with hypokalemia and makes it harder to correct. Continuous cardiac monitoring if giving IV K+ vac. Institute fall safety measures due to muscle weakness. Magnesium imbalances, normal.
About 1.5 to 2.5 milli-EQL. Important for neuromuscular function, cardiac rhythm.
Hypomagnesemia, MAG 1.5, causes.
Chronic alcoholism is a major cause. Poor intake, GI loss, renal wasting. Also prolonged loop thiazide diuretic use, GI losses. Symptoms: increased neuromuscular excitability, muscle weakness, tremors, tetany, hypoactive deep tendon reflexes, contrary to what you might expect, positive Schwastax and Trousseau's signs like hypocalcemia, tachycardia, arrhythmias like torsades, potential respiratory depression, seizures, coma. Priority: institute safety measures, seizure precautions, and fall precautions. Replace magnesium IV or orally. Hypermagnesemia, MAG 2.5, cause.
Most common cause is kidney disease, CKD, especially if taking magnesium-containing antacids or laxatives. Impaired excretion, symptoms. Opposite of hyperdecreased neuromuscular activity, bradycardia, hypotension, cardiac arrhythmias, risk of cardiac arrest. Diminished or absent deep tendon reflexes, muscle weakness, flaccid paralysis, respiratory depression.
Priority intervention for hypermagnesemia.
Discontinue any magnesium-containing medications immediately. If severe symptoms or high levels, administer IV calcium gluconate immediately. It acts as an antagonist to protect the heart. Prepare for potential hemodialysis if levels are dangerously high. Sodium interventions, normal.
135 to 145 milli-TQL. Major determinant of plasma osmolality. Crucial for neurofunction.
Hypernatremia, sodium 145.
Causes: usually relates to water loss exceeding sodium loss, dehydration, diabetes insipidus, fever, excessive sweating, or excessive sodium intake. Symptoms: the neurological effects are most devastating. Confusion, agitation, restlessness, irritability, lethargy can progress rapidly to seizures, coma, and permanent brain damage. Also, thirst, dry mucous membranes, maybe hypertension. Treat the underlying cause, usually give water hypotonic fluids. Administer fluids slowly, rapid correction risks cerebral edema, hyponatremia, sodium 135. Cause of
Can be from excessive water gain, dilutional like in SIDH, heart failure, or psychogenic polydipsia, or from excessive sodium loss, vomiting, diarrhea, diuretics. Symptoms: also primarily neurological due to cerebral swelling, headaches, confusion, lethargy, muscle twitching, nausea, vomiting, progressing to seizures and coma. Critical risk of brainstem herniation when sodium levels fall rapidly or below 120 milliQL. Treatment depends on cause and volume status. Often fluid restriction for dilutional hyponatremia. For severe symptomatic hyponatremia, may administer 4V hypertonic saline, 3% ACL, very cautiously in an ICU setting. Warning: rapid correction causes osmotic demyelination syndrome, ODS, permanent brain damage. Correction rate must be slow and carefully monitored. Institute seizure precautions. Okay, moving to gas exchange. Asthma, classic symptoms.
The triad: cough, often worse at night, wheezing, high-pitched sound on expiration, and shortness of breath, dyspnea, danger sign. Normal PECA2 during a severe attack might mean the patient is tiring out and heading towards respiratory failure.
Management, meds.
First line for long-term control is usually inhaled corticosteroids, ICS, to reduce inflammation. Short-acting beta-adrenergic agonists, SABAs like albuterol, are quick relief or rescue inhalers for acute symptoms. Long-term control might involve LABAs combined with ICS.
Inhaler education points.
Super important. Rinse mouth after using ICS to prevent oral thrush, candidiasis. Use a spacer device with PMDIs, pressurized meter dose inhalers. If technique is poor, helps get more med to the lungs. For PMDI technique, shake well, exhale fully, position inhaler, open or close mouth, actuate while breathing in slowly and deeply, hold breath for 10 seconds, wait 1 minute between puffs. DPIs, dry powder inhalers, require a fast, deep inhalation by the patient. Don't shake and don't exhale into the device.
Peak flow readings. Zones.
Helps patients monitor their control. Green zone, 81% of personal best. Good control. Yellow zone, 60 to 80%. Caution, asthma worsening, may need to increase meds or use rescue inhaler. Red zone, 50%. Medical alert. Use rescue inhalers immediately. Seek medical treatment.
Chest tube nursing interventions. Purpose.
It's a closed drainage system inserted into the pleural space to remove air, pneumothorax, fluid, pleural effusion, or blood, hemothorax, and allow the lung to re-expand.
Water seal chamber observations.
Gentle bubbling initially, if removing air is normal. Tidling, fluctuation of water level with breathing, is also normal and shows the system is patent. Continuous bubbling in the water seal chamber usually indicates an air leak somewhere in the system, patient or tubing. Keep the drainage system below the level of the patient's chest. Always. Keep it secured.
Nursing care focused.
Assess respiratory status frequently. Monitor drainage output, amount, color, consistency. Check for air leaks. Ensure tubing is patent, not kinked. Check dressing integrity. Keep emergency equipment at the bedside.
What emergency equipment?
2 padded hemostats for clamping tube briefly if needed. Check policy. Sterile petroleum gauze for occlusive dressing if tube dislodges. Dry, sterile gauze and a bottle of sterile water to create an emergency water seal.
What if the tube accidentally comes out?
Immediately apply an occlusive dressing petroleum gauze covered with dry gauze taped on 3 sides. Allows air to escape but not enter. Notify provider immediately.
What if the tube disconnects from the drainage system, atrium?
Don't clamp it. Immediately place the open end of the chest tube into the bottle of sterile water. This creates a temporary water seal and prevents air from entering the pleural space. Then get a new drainage system set up.
Cystic fibrosis, CF. Education. Priorities.
Promote removal of thick pulmonary secretions. Prevent and manage infections. Maintain adequate nutrition. Education includes recognizing early signs of infection, understanding the need for frequent, sometimes multimodal antibiotics.
Airway clearance techniques.
Absolutely vital. Includes manual chest physical therapy, CPT percussion and vibration, using an HFCWO vest, the shaker vest, PP masks, positive expiratory pressure. Pancreatic enzyme replacement therapy must be taken with all meals and snacks to aid digestion. Also need supplemental fat-soluble vitamins, ADEK, due to malabsorption. Exercise is actually very beneficial. Vaccinations, flu, pneumococcal are critical.
Key cues for CF.
Those thick, viscous secretions affecting lungs, pancreas, other organs. Increased chloride in sweat. The classic story is parents noticing saltiness when kissing babies. Pulmonary, chronic productive cough, wheezing, recurrent infections, eventual lung damage. Non-pulmonary, pancreatic insufficiency, malabsorption, failure to thrive, CF-related diabetes later on.
Diagnosis.
The sweat chloride test is the gold standard. A chloride level of 60 millieql or greater on 2 separate occasions is diagnostic. Management is lifelong, focusing on managing symptoms and preventing complications. Infection control, airway clearance, nutritional support are pillars.
And another note, our source material didn't include track care details.
Okay. SIDs, sudden infant death syndrome, education. Safe sleep is paramount.
Key points.
Place baby on their back for all sleep times, naps, and nighttime. Use a firm, flat sleep surface like a mattress in a safety-approved crib. Keep the sleep area clear. No pillows, blankets, stuffed toys, crib bumpers, padded side rails, or weighted sleep sacks. These are suffocation hazards. Room sharing, not bed sharing, is recommended.
Risk factors.
Sibling death, asides, low birth weight or prematurity, maternal smoking or substance use during pregnancy, secondhand smoke exposure after birth, recent viral infection, soft or loose bedding, overheating, and co-sleeping, bed sharing.
RSV, respiratory syncytial virus. Education and risk factors, precautions.
Highly contagious, requires contact and droplet isolation. Strict hand washing is crucial. Home care focuses on symptom management. Nasal saline drops and suctioning to clear airways, ensuring adequate fluid intake, monitoring for respiratory distress, no smoking exposure, limit exposure to others if possible. Prevention for high-risk infants. Palovizumab, Synagis, a monoclonal antibody given monthly during RSV season.
Who is high risk for severe RSV?
Infants who weren't breastfed, those exposed to secondhand smoke, premature infants, babies with chronic lung disease like bronchopulmonary dysplasia or congenital heart disease. RSV affects almost all children by age 2, but it's usually like a bad cold in healthy older kids adults.
Priority cues for severe RSV.
Look for signs of significant respiratory distress. Cyanosis, bluish discoloration, tachypnea, respiratory rate 70 breaths, apneic episodes, pauses in breathing, diminished breath sounds, severe retractions, nasal flaring. Early signs might just be runny nose, low fever, poor feeding cough. Progressed signs include increased work of breathing, air hunger, audible crackles or wheezing, restlessness. Need hospitalization if severe.
Okay, perfusion. Labs and medications. Cardiac biomarkers for MI.
Troponin I and troponin T are the most sensitive and specific for cardiac muscle damage. They rise within hours and remain elevated for up to 2 weeks. CK-MB is also cardiac specific, but returns to normal faster, usually within 2-3 days. Myoglobin rises very quickly, but isn't cardiac specific.
Lab specific to DVTPE.
A D-dimer assay measures fibrin degradation products. It's sensitive, and negative result helps rule out a clot, but not specific, can be elevated for many other reasons. Coagulation studies.
PT, prothrombin time, is used primarily to monitor warfarin Coumadin therapy. PTT, partial thromboplastin time, or APTT, activated PTT, is used to monitor heparin therapy. Therapeutic goal is usually 1.5–2.5 times the control value. INR, International Normalized Ratio, is the standardized way to report PT for warfarin monitoring. Therapeutic range for most indications is 2.0–3.0.
What to monitor with anticoagulants?
Signs of abnormal bleeding. That includes obvious things like hematuria or melena, but also subtle signs like unusual bruising, persistent oozing from cuts or gums, or changes in mental status, which could indicate an intracranial bleed. Monitor the specific lab, PT-TAP-PTT for heparin, PT-INR for warfarin. For ACE inhibitors, monitor electrolytes, sodium, potassium, risk of hyperkalemia, and creatinine, kidney function. Education for hypertension, diagnosis.
Based on 2 or more elevated BP readings greater than 1,280 mmHg, taken on separate occasions. Important note, in hypertensive crisis needing IV vasodilators, monitor intake and output INO very closely to manage fluid status effectively.
Lifestyle changes are huge.
Absolutely. The DAH eating plan, dietary approaches to stop hypertension, rich in fruits, vegetables, whole grains, low-fat dairy, low in saturated fat and sodium, low sodium intake, weight loss if overweight, regular aerobic activity, limited alcohol intake, avoid tobacco. Emphasize that treatment aims to control hypertension, not necessarily cure it. It's usually lifelong management.
Medication adherence.
Critical. Warn patients never stop medications abruptly, especially beta blockers or clonidine, due to risk of severe rebound hypertension. Encourage home BP monitoring and regular follow-up appointments.
Quick overview of med-MOAs, first-line agents.
Often thiazide diuretics, ACE inhibitors, ARBs, or calcium channel blockers, CCBs.
Diuretics like HCTC.
Decrease blood volume and vascular resistance. Monitor for dehydration, hyperglycemia, and especially hypokalemia. Check weight, INO, electrolytes.
ACE inhibitors and Strop like lisinopril.
Block angiotensin conversion, leading to vasodilation and reduced aldosterone. Decrease peripheral resistance, common side effect, persistent non-productive cough. Can cause hyperkalemia. Most serious potential side effect, angioedema, swelling of face, lips, tongue, airway, life-threatening emergency.
ARBs and Ensartan like losartan.
Block angiotensin receptors. Similar effects to ACE inhibitors, but usually do not cause the cough. Also risk hyperkalemia and angioedema, less common than ACEs.
Calcium channel blockers like diltiazem, amlodipine.
Block calcium entry into smooth muscle, causing vasodilation. Some also decrease heart rate, like diltiazem, verapamil. Side effects, hypotension, dizziness, peripheral edema, constipation, especially verapamil.
Beta blockers end in lol, like metoprolol.
Decrease heart rate and contractility, reducing cardiac output, side effects. Bradycardia, hypotension, fatigue can cause bronchospasms. Use cautiously in asthma COPD. Contraindications: systolic BP less than 90, heart rate less than 60 BPM. Avoid abrupt discontinuation. Watch for interactions. Avoid ginkgo, ginger supplements.
Differences in PVD disorders. Arterial disease first.
Risk factors: atherosclerosis, smoking, diabetes, hypertension, hyperlipidemia. Key Q: intermittent claudication leg pain, usually calf, brought on by exercise, relieved by rest. Physical exam: skin is often cool, pale, especially with elevation, may be shiny with hair loss. Nails brittle. Ulcers, if present, are typically on toes, heels. Lateral malleoli often look punched out, painful. Pulses: decreased or absent peripheral pulses are a key finding. Education focuses on foot care, smoking cessation, exercise, walking to point of pain, resting, resuming.
Chronic venous insufficiency, CVI.
Problem is incompetent valves in the veins, leading to venous stasis, blood pooling, and chronic venous hypertension. Cues: edema, especially lower leg, skin discoloration, brawny, brownish, stasis dermatitis, itching, scaling, varicose veins. Ulcers, if present, are typically around the medial malleolus, shallow, irregular borders, often with drainage. Pulses are usually present. Education: elevate legs, avoid prolonged standing, sitting. Proper use of compression therapy, stockings, wraps is essential. Protect skin from injury.
DVT, risk factors, management education. Risk factors, Virchow's triad.
Yep, the triad summarizes it. 1. Alterations in blood flow, stasis. Immobility, surgery, long travel, heart failure. 2. Vascular endothelial damage, trauma, surgery, central lines, IV drug use, inflammation. 3. Hypercoagulability, inherited disorders, cancer, pregnancy, estrogen therapy, oral contraceptives, HRT, dehydration, sepsis, sudden withdrawal of anticoagulants.
Management prophylaxis.
Pharmacological, often low molecular weight heparin, LMWH, like enoxaparin or unfractionated heparin subcutaneously. Mechanical, graduated compression stockings, intermittent pneumatic compression, IPC devices, early ambulation after surgery, leg exercises, elevate foot of bed slightly.
Treatment with anticoagulants. Heparin.
Unfractionated heparin, often given IV initially for treatment, requires frequent PTT or APTT monitoring. Reversal agent, protamine sulfate.
Warfarin.
Oral anticoagulant, takes several days to reach full therapeutic effect, often bridged with heparin initially. Requires regular PTINR monitoring. Reversal agent. Vitamin K, many food drug interactions, especially leafy greens high in Vit K. LMWH, given subcutaneously. More predictable response, usually doesn't require routine lab monitoring, though anti-AXA levels can be checked. Do not rub the injection site, increases bruising. Comes in pre-filled syringes, leave the air bubble in.
Priority DVT assessment. What's contraindicated?
Look for unilateral leg swelling, warmth, redness, tenderness, pain. Contraindicated. Holman's sign, pain in calf on forced dorsiflexion. It's unreliable and potentially dangerous as it could dislodge the thrombus. Interventions: elevate the affected extremity. Bed rests initially may be ordered, controversial. Apply warm compresses, administer anticoagulants as ordered. Monitor for the main complication, which is pulmonary embolism, PE, a life-threatening emergency if the clot travels to the lungs.
Lifespan changes in cardiac function and ACSMI. Quick notes.
Genetics play a role in cardiac risk. Pediatric DVT-VTE, often linked to central lines or inherited clotting disorders. VPE risk increases in adolescents, young adults using contraceptives. Pregnant women have higher VTE risk. DVT incidence increases significantly in adults over 40.
Acute coronary syndrome, ACS, myocardial infarction, MI presentation.
Classic is severe substernal chest pressure or pain, often described as crushing or squeezing, may radiate to jaw, neck, shoulders, left arm. Associated symptoms: nausea, vomiting, dizziness, shortness of breath, diaphoresis, profuse sweating. Women, elderly, diabetics may have atypical symptoms, fatigue, indigestion. Immediate priority: relieve pain ischemia, prevent further myocardial damage. Interventions follow MONAB principles: morphine, oxygen, nitroglycerin, aspirin, beta blocker. Though order varies, oxygen if sat 94%, aspirin chewed immediately, nitroglycerin SL, morphine if pain persists. Need EKG, cardiac biomarkers.
Final segment. Infection and inflammation. Inflammation general.
It's the body's adaptive, non-specific response to injury or infection. Goals to remove damaged cells, pathogens, exudate via phagocytosis, initiate healing. The 5 cardinal signs: redness, rubor, warmth, calor, swelling, a tumor, pain, dolor, and impaired function, functionalisa. Remember, the suffix itis usually means inflammation, phlebitis, appendicitis. Diagnostic labs often show elevated ESR and CRP.
PPE, order for putting on donning.
Gown first, then mask or respirator, then goggles or face shield gloves last.
Order for taking off, doffing, critical to avoid self-contamination.
Gloves first, dirtiest, then goggles, face shield, then gown, mask, or respirator last. Remove outside the room if possible for airborne. Always perform hand hygiene after removal.
Contact precautions. Examples. Needs.
For organisms spread by direct and indirect contact, MRSA, VRE, C. diff, scabies, requires private room or cohorting, gown and gloves for anyone entering the room, dedicated equipment preferred.
Airborne precautions. Examples. Needs.
For tiny droplet nuclei that remain suspended in air, measles, TB, varicella, chickenpox, requires a private negative pressure airflow room, door kept closed. Healthcare workers need a fit-tested N95 respirator before entering.
Droplet precautions. Examples. Needs.
For larger droplets spread by coughing, sneezing, talking, pertussis, influenza, meningitis, most pneumonias, requires a private room or cohorting. Healthcare workers need a surgical mask and eye protection when working within 3 to 6 feet of the patient. Patient wears mask if leaving room.
Special point about C. difficile?
Alcohol-based hand sanitizer is ineffective against C. diff spores. Must wash hands with soap and water using friction. Use bleach-based disinfectants for environmental cleaning.
Education and prevention for specific infections. Influenza.
Transmitted by droplets. Requires droplet precautions. Best prevention. Annual vaccination. Critical. Never give aspirin or salicylate-containing products to children or teens with viral symptoms, flu, chickenpox, due to risk of Ray's syndrome. Antivirals, like oseltamivir, are most effective if started within 48 hours of symptom onset. Key symptoms: abrupt onset of fever, myalgia, headache, malaise, cough, sore throat, contagious period, about 1 day before symptoms start to 5-7 days after.
Pneumonia. Earliest sign of hypoxia.
Often a change in mental status, especially in older adults, new onset confusion, restlessness, or agitation. Prevention: annual influenza vaccine and pneumococcal vaccines, PCV13, PPSV23, as recommended. Priority interventions: position in high Fowlers to maximize lung expansion. Encourage use of incentive spirometer. Increase fluid intake to thin secretions. Monitor respiratory status closely.
Pneumonia manifestations.
Diagnosis: fever 100.4 degrees F, 38 degrees C, chills, productive cough, sputum may be rest-colored purulent, craggles or raunchy on auscultation, dyspnea, tachypnea, pleuritic chest pain, sharp pain worse with breathing, sometimes a pleural friction rub. Diagnostic: chest x-ray is key. Obtain sputum culture before starting antibiotics.
Tuberculosis, TB transmission. Precautions.
Airborne transmission via droplet nuclei. Requires airborne precautions, negative pressure room, N95 respirator for staff. Hallmark symptoms: persistent cough, often 3 weeks, purulent sputum, maybe blood-tinged, fatigue, lethargy, night sweats, low-grade afternoon fevers, unexplained weight loss.
Definitive diagnosis.
For active TB disease: sputum culture positive for acid fast bacillus. AFB. Smear microscopy provides rapid suspicion, but culture confirms. Skin test, TST-PPD, or blood test, IGRA, only indicates exposure latent infection, not active disease.
Active TB treatment. Duration. Drugs.
Long course, typically 6-9 months. Initial phase, usually 2 months, involves 4 drugs: isoniazid, INH, rifampin, pyrazinamide, ethambutol, RIPE, followed by continuation phase, usually 4-7 months, with INH and rifampin. Adherence is critical to prevent drug resistance, often used directly observed therapy, DOT.
Key drug side effects teaching. Rifampin.
Causes harmless red-orange discoloration of all body fluids, urine, sweat, tears, worn contact lens wearers. Also decreases effectiveness of oral contraceptives, need backup birth control. Hepatotoxic.
INH, isoniazid.
Can cause peripheral neuropathy, tingling numbness in hands, feet, usually prevented by giving pyridoxine, vitamin B6 concurrently. Take INH on an empty stomach 1 hour before or 2 hours after meals. Also, hepatotoxic monitor liver function for both.
Latent TB treatment.
Usually involves INH prophylaxis for 9-12 months or shorter regimens with other drugs to prevent progression to active disease. Latent TB definition: positive skin blood test, negative chest x-ray, no symptoms. Note: BCG vaccine can cause a false positive skin test result.
Nurse's role: informed consent. Clarifier role.
The surgeon is responsible for explaining the procedure, risks, benefits, alternatives. The nurse's role is primarily to verify that the surgeon has discussed this with the patient and that the patient understands, and to witness the patient's signature. We can clarify information previously given by the surgeon, but if the patient has new questions or expresses significant misunderstanding about the procedure itself, we must call the surgeon back to speak with the patient again. Consent must be signed before administering any pre-op medications that could impair cognitive function.
Last one. Osteomyelitis. What is it?
It's an infection of the bone. It can be acute or chronic. Often results from extension of soft tissue infection, direct bone contamination, open fracture, surgery, or bloodborne spread, common in diabetics with foot ulcers. Requires long-term antibiotic therapy, often IV initially, then oral for weeks, months. Ensure patient completes the entire regimen. Infected area is typically painful, swollen, warm, extremely tender. Pain is often constant, pulsating, worse with movement. May have systemic signs like fever, chills.
Wow. We covered an immense amount of critical information there really fast. That wraps up this Monday morning panic review. Hopefully, this hit the key points you need for your exam.
Absolutely. Remember, just memorizing isn't enough. Try to understand how these concepts connect, how one system impacts another. Thinking clinically will help you apply this knowledge effectively. Now take a deep breath, trust your preparation, and go nail that exam.